Lack of access to primary care in the United States is a commonly cited problem, with culprits including burnout, administrative burdens, and income disparities between primary care physicians and specialists. In recent years, another factor contributing to access gaps has been primary care physicians leaving traditional practices for concierge and direct primary care practices. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Zirui Song, an associate professor of healthcare policy and medicine at Harvard Medical School and a general internist at Massachusetts General Hospital. Dr. Song has co-authored a perspective article about the evolution of primary care into a private free market commodity. Dr. Song, what are some of the burdens and challenges facing primary care physicians in traditional practices in the United States?
In traditional practices, primary care physicians often face the challenges of administrative burdens, including prior authorizations and working through the utilization review processes of insurers. They also have increasingly faced burnout with the aging of the population, the increased complexity of their patient panels, as well as challenges towards the loss of autonomy felt through increased ownership of their practices by larger health systems and corporate parents.
In your article, you describe the expansion of concierge and direct primary care practices. How is care delivered and paid for under those models?
In concierge practices, typically practices are financed by both retainer or membership fees from the patients, as well as the typical reimbursements from health insurers. On an average annual basis, the membership or retainer fees could total from about several $1,000s to tens of thousands of dollars. On top of that, services delivered are billable and reimbursable through both public and private insurers. In direct primary care practices, the membership or retainer fees are typically lower on average, though still with a quite wide range, often from several $100s per year in total to several $1,000s per year. In the direct primary care practices, we have learned that typically physicians do not work with insurers and therefore do not bill their services through claims, as would be commonly seen today with public and private insurers. Rather, the financing comes from mostly the direct membership fees, and the administrative costs of running the practice are also lower. For the patients, the costs of many of these common services, from labs to basic imaging to medications, especially generic medications, and basic procedures, are typically paid on a fee schedule that often is negotiated between the direct primary care practice and vendors of those labs and imaging services. And with bulk purchasing, there is some market power on the part of direct primary care practices to obtain discounts for patients.
So, what's drawing primary care physicians to these models?
Well, for primary care physicians, the exit from a traditional primary care practice to one of these so-called free market models of practice does offer some improvements in quality of life, the quality of the practice experience, and in the day-to-day mechanics of delivering primary care. Physicians often experience an increased job satisfaction, sometimes phrased as, quote unquote, taking primary care back from their previously less satisfactory roles that made them feel more like gatekeepers or administrative clinicians. Physicians similarly feel greater clinical autonomy in decision-making. They can receive more take-home pay and overall have reported an improved work-life balance. At the same time, they've reported that practice management costs are often lower because the costs of working with insurers and going through the prior auths and utilization review processes are less, given that many of these practices do not go through insurance. And these benefits have also created increased time with patients.
And then the patients. What motivates patients to seek out concierge and direct primary care practices?
Currently in our country, over 1/3 of patients don't have a usual source of primary care. This has been a decades-long, many decades struggle in the diminishing supply of primary care relative to its demand. So patients who have the means and are willing and able to pay retainer and membership fees are often choosing these free market models of primary care practice to obtain better access to their physician, shorter waiting times. They often receive longer visits if that's needed. And in the case of concierge practices, often patients receive more personalized or exclusive care, sometimes it's termed. And what that entails is home visits, accompanied visits to specialists at times, direct email or phone communication on demand, and the ability to reach your physician when needed without needing to schedule an appointment and wait for that appointment.
Nonetheless, despite these benefits for participating physicians and for patients, you say in your article that these private free market primary care models involve important trade-offs for society as a whole. What are some of those trade-offs?
One of the primary trade-offs is that for the rest of society remaining in traditional primary care practices, the exit of primary care physicians toward these free market practice models means that there are fewer primary care physicians remaining in traditional practices to take on an even larger patient load and demand from patients. So, for example, if a classic primary care physician who is full-time has roughly 2,000 or more than 2,000 patients, let's say, an exit toward a concierge or a DPC practice typically involves the physician taking 300, 400, 500 of the patients from the existing panel to the new practice. And that could leave anywhere between 1,500, 1,600, or more than 2,000 patients left without a primary care physician in the existing practice. Now, the existing practices will work incredibly hard to reassign those patients to other physicians in those practices. But of course, those other physicians are often also at full capacity and are unable to absorb or easily absorb these new patients. And absorbing these new patients now puts more strain on those existing physicians, thus making it easier or more sensible for them to leave the traditional primary care practice as well. This could create a so-called vicious cycle where the exit of every primary care physician to the free market makes it more likely that the next primary care physician will also exit to the free market. The second important trade-off is equity. And that is because the ability to afford these membership and retainer fees is not even across society. Most members of society would probably not be able to find a discretionary several thousand or tens of thousands or even several $100s over the course of a year to pay for primary care. And so what we're seeing is a likely separation of primary care into a class of those who can afford it into these free market private models with, of course, improved access and many benefits for those patients and physicians. And then another class of the remainder larger portion of society who cannot afford entry into these new models.
Are there steps that policymakers or regulators could take to help address some of those concerns?
On the issue of membership fees or retainer fees, they are currently left to the discretion of practices and really dictated by what the market will bear. There is some analogous sense of the pricing of these membership fees, similar to the launch prices of drugs, if you will, where there are no regulations governing these prices. And it's really the choice of the provider or the choice of the manufacturer for what the market price is. And then on the demand side, you see who is able to afford it and enter. And of course, there is going to be some kind of market equilibrium that emerges where the average price can be affordable for the average patient in these practices. But the regulation of such prices is not something that current state or federal policies have touched on, nor is it something easy to do. This is a private market analogous to private practice psychiatry, where the government is really at a far distance away relative to the setting of these prices. And over time, the growth of these membership or retainer fees is also dictated by what the market will bear. In terms of traditional primary care practices, there are likely many things that policymakers could do to strengthen those practices. One way perhaps to slow the exit of physicians towards these private market models is to make existing primary care practices more appealing to practice in, to support them through increased staff, increased financing of resources, everything from supplies to help for physicians on the front lines to deliver care, to help with documentation, to the use of technology to make documentation and going through prior authorizations easier for physicians, and ultimately to affecting the fee schedule that primary care remains governed under today for over the last 3 decades or so. There has been lots of discussion in recent decades about the payments for primary care services relative to payments for procedural or non-primary care services. And that discussion continues in our nation's capital today. The last point here is that policymakers in many states are working on primary care legislation that aims to raise the proportion of healthcare spending allocated to primary care, in some cases paired with moving primary care away from pure fee-for-service payments. So this leads to another consideration for policymakers, which is that the exit of primary care physicians to free market practices affects alternative payment models, including global budget or accountable care organization contracts. For both public and private insurers, patients are attributed to provider organizations in such contracts based on the organizations their primary care physicians work in. When a primary care practice does not participate in insurance, there is no such attribution of patients to the provider organization in the contract. These contracts also require quality measurement and reporting, often focused on primary care measures, including chronic disease management and cancer screenings. Practicing outside of insurance removes these requirements. This does reduce administrative burden, but it also leaves patients who are now fully consumers in the free market as the sole arbiters of quality. Therefore, if policymakers want alternative payment models to succeed in making provider organizations more accountable for quality and spending with primary care as the quarterback, they have an incentive to help traditional primary care succeed.
Finally, what do you think this trend toward increased reliance on the free market for primary care is going to mean for privatization in the healthcare system more broadly?
That's a great question. Primary care is certainly not the only specialty to have experienced this type of evolution towards the free market. Indeed, since the 1960s, mental health care and the field of psychiatry and private practice psychology has established this model of private practice as an incredibly popular option. Over the last 5 or 6 decades, data suggests that about half of our nation's labor force in mental health care, psychiatry and psychology included, is allocated to private practice, where similar to concierge practices and DPC practices, the fees are set by the private market, and often the billing is done outside of insurance. We are beginning to see some other specialties outside of primary care move in this direction as well, although that's been less well established, perhaps simply because the volume of those services are far less than the volume of primary care. But overall, as access to healthcare on the whole diminishes with an aging population and many estimates of physician supply shortages nationwide across both cognitive or non-procedural and procedural specialties, as long as care can be delivered in a home office in a non-facility setting, not attached to a hospital, not attached to an operating room, not attached to facility structural inputs, then it's possible that more specialties and more services will also face an incentive to move outside of the insurance model or outside of facility-based practice into more free market, private types of settings. Ambulatory surgery care is a version of this, although that is, especially in the status quo, still facility-based. But you can imagine other types of minor procedures that can be moved outside of facility settings as well that the private free market can accommodate.
Thank you, Dr. Song.